Hyderabad, and he just conducted an IAP Neocon, a well-known researcher, and more than 100 publications to his name. I may be underestimating the number, but and he's a great guy and a nice friend. Over to you, Akash.
Uh, Thank you so much for that kind introduction. And I think after that excellent lecture on modes of ventilation, my job is made little easy. And in the next 15-20 minutes, we'll be talking about pulmonary graphics. Basically, these days, our effort is more on being non-invasive, being a gentle neonatologist rather than a hardcore neonatologist who always have a tube and a laryngoscope in hand. We prefer not to use these tools unless and until we are forced to. So, day by day, we are trying to make ventilation as comfortable to the baby as possible. When we begin the ventilation, we only had X-rays to know about the condition of the lung. Then subsequently, we had blood gases. And the problem with both these two modalities, that is X-ray and blood gases, is that they give a snapshot of what is happening with the lung or the milieu interior. We wanted something which can tell us the real-time happenings in the patient lung, how the compliance is changing, how the lung is changing, or whatever settings we are being putting on the ventilator, whether they are appropriate for the baby or not. Sometimes for the same baby, whatever settings we may begin with, they may not be appropriate subsequently, because lung compliance, resistance, they are dynamic phenomena and they keep on changing with the lung disease, whether it is progressing or it is improving. So for this to happen, there is something called as pulmonary graphics, which is just like a snapshot, and where you just look at the graphics and you can identify various misadventures, various settings, whether they are appropriate or not. But remember, the heart of the modern ventilation is a flow sensor. So whether you are using a patient triggered ventilation or you want to tell about the patient condition or the settings, you need a flow sensor which is working there. So always try to maintain this flow sensor in a good condition and always see whether it is working or not. Without this flow sensor, whatever modes we may use, whether SIV, assist control, or graphics, they may not be reliable. So always make it sure it is in place and it is in a working condition. With the help of graphics, we can evaluate the patient lung condition. We can also get a feedback, just like our hypothalamus pituitary axis. We also can get the feedback from the patient and whether the settings which you have set up are appropriate or not. How is the lung condition changing, whether the compliance is improving, it's worsening. That also can be done with the help of graphics. And also we can know whether the lung is in a condition where we can think of weaning or not. And as I said, that why do we want to avoid ventilation is because ventilation is not easy. It is comes with lots of problems, or something which we call as ventilation induced lung injury, or there can be other misadventures like sometimes pneumothorax, tube leakage. They can also be picked up with the help of these graphics. To begin with, graphics are broadly divided into two types. One are the scalars and the other is loops. We'll be discussing them one by one. So first is scalar. So scalars are three types. So the main three variables which we measure are the pressure, volume, and flow. So as you can see on the slide, whenever we plot these variables against a time, they are known as scalars. For example, pressure, flow, and volume, they are plotted on y-axis and the time is there on the x-axis. We'll go to the first scalar, that is pressure versus time. So you will always see that the pressure time curve will never start from the zero. It will always start above the baseline. This is because there is something called as PEEP. The pressure is never zero. There is always PEEP, which is given both during inspiration and expiration. So it will always start from PEEP. Then as the exhalation valve closes, the pressure will start increasing. So this is the inspiration and it will reach to the PIP which we have set. So the peak of this wave gives us the PIP. And then as the exhalation valve opens, the pressure will drop again and come back to PEEP. So from this to this, we have TI, and from this point to this is TE. So this is a pressure time graph or a pressure scalar, where the peak of this graph gives us the PIP, and we can also see TI and TE from this graph. Now coming to the other scalar, this is, in fact, if you want to learn graphics, you can just learn two curves and you will know 90% of the diagnosis. So one of the important curves is the flow curve. This scalar is different from pressure time and volume time because it has a positive wave and a negative wave. So to begin with, the pressure in the circuit is always higher than the lung pressures. Suppose in the lung we have the pressure of 5 and we have set a PIP of 15. So there is a gradient of 10 between PIP and P. So initially the flow will go from the circuit to the lung as the acceleration closes. So the flow will keep on increasing. As the pressure starts building up in the lung, from, for example, from 5, it now becomes 10. So the gradient decreases from initial gradient of 10, it now becomes 5. So the flow will start decreasing, decreasing, decreasing till the pressures have equilibrated. That is, the pressure in the circuit and pressure in the lung are equal. So there will be a zone of no flow. After that, once the acceleration valve opens, then again there will be expiration. So from this to this, we have inspiration, and from this to this, we have expiration. So this curve is very important to know the adequacy of TI and TE. If we have set a short TI, so you will see that before the inspiration comes to the baseline, the expiration will start. This indicates that the TI is very short. Similarly, if there is air trapping or the expiration time is less, the inspiration will start before the expiration comes to the baseline. For example, in this slide, usually when we talked about the uh, TI and TE, usually it's a smooth slope and then comes to the baseline and then drops. Whereas if you see the flow time graph here, there is a sudden tapering of there. Initially, we had set a TI of 0.3 as excuse me just a second. Sorry for the disturbance. So here we have seen that there is an abrupt tapering. So initially we had set a TI of 0.3. As we increase the TI to 0.45, you will see that the slope has again come back to the normal. Now what this has done is, initially you can see from the same pressure of PIP of 10 to 12, we were getting a tidal volume for around 20. So after normalizing, giving enough time for the inspiration to happen, for the same pressure, we are now getting a tidal of around 25. So this is the benefit of giving adequate TI and TE for the ventilation to happen correctly. The other thing we talked about is something known as inspiratory hold. This was also discussed in the previous lecture. So normally this is a zone of zero flow. What does it mean is that the lungs are already inflated. Whatever PIP we had set, we have already achieved it. But because the TI is long, so the lung has to be expanded with that extra pressure for that extra time, which is actually not helping our ventilation. But just because we have set a long TI, the lung is expanded, and so we are giving a barotrauma to the lung. So this is zone of zero flow. So again, this tells us that the TI is very high. So we need to come down on TI. Once we adjust it, it becomes again a normal. So again, this flow time also tells me about the mode of ventilation, whether I'm using a pressure ventilation or I'm using a volume ventilation. In volume ventilation, there is always a fixed tidal volume and flow is constant. So we'll always get a square wave. So the inspiration will always be a square wave, whereas in the pressure ventilation, it will be a sine wave. So again, with we can tell whether it is a pressure ventilation or a volume ventilation. Similarly, if there is increased resistance, so what will happen in the resistance? So we see the first graph, this is a normal graph. This inspiration goes to the peak inspiratory flow. Then as the gradient decreases, the flow ceases, comes to the point of zero flow, and then this is expiration. Again, this is the peak expiratory flow. And again, as the gradient decreases, it comes back to the baseline. Now, whenever there is increased resistance, usually it happens during expiration. So what will happen is the peak expiratory flow. You can see the peak of this uh, expiratory graph comes down. So the peak expiratory flow will decrease, and also it will take longer time now to come down to the baseline. Usually, when you auscultate such babies, they may have a wheeze or a bronchospasm, and whenever we give a bronchodilator, and it again comes back to the normal. Usually, this happens in BPD patients. We can also identify ear leak. If it doesn't come to the baseline and the inspiration starts from this point, this also tells me that there is this amount of air leak. Similarly, this graph will also tell me if there's a air trapping or auto peep. So in the previous, we also discussed about the auto peep. One of the things by which you can, apart from the clinical monitoring, by which you can pick up auto peep is graphics. So you can see before coming to the baseline, the next flow time graph has already started. So it starts below the baseline. So this much air trapping happens. And with each breath, it will keep on increasing. And by looking at flow time graph, we can also pick up auto peep or air trapping. So flow timers tells us type of ventilation, that is pressure versus volume. In volume, we will have a square wave. It also tells about the adequate TI and TE. So the inspiratory hole should be as small as possible. It also tells me about the air leak and trapping, although there are other graphics also to tell us about the same. And also, it also tells me about the increased resistance, in which the peak expiratory flow will come down and it will take longer time to reach the baseline. Then we have something called as volume time. This is the simplest of all. Again, we have a volume on y-axis, we have time on x-axis, just like other scalars. And this, the peak of this graph gives me, since we are talking about volume here, in the pressure time graph, the peak was PIP. In this, in the flow, it was peak inspiratory flow rate. And here, since this is a volume graph, it is the tidal volume. So this is my inspiration, this is my expiration, and this is TI, and this is TE. And usually, whenever we have a leak, the volume time graph will look like this and it will not come to the baseline, telling me that there is a this amount of leak, which may be because of the small ET tube or leak in the circuit. Coming to the other type of graphs, that is loops. Loops are different from scalars because here we are plotting one variable against the other. And the most common or important one to learn is PV loop, where volume is on the y-axis and pressure is on the x-axis. So this is the PIP, and this on the y-axis is the tidal volume. So this is the inspiration and this is the expiration. So usually it should have a 45-degree angle. Less the compliance, the graph will be more flat or more to the right side. Good lung, or after giving surfactant, when the compliance is good, it will be shifted more towards the left. That tells me that with each increase in volume, there is an equal change in the volume. And that is what we want. We don't want to give pressures without gaining or without benefiting from increase in the volume. So that is the wastage of the pressure and causing more barotrauma. So again, this loop will never start from zero. It will always start from here because this is something called as PEEP. And beyond this point, you will see as we increase the pressure, there will be almost a good increase in the volume, telling me that the lung compliance is good. Now, imagine there are three lungs. So, what is the pink one telling me? That you can see from here to here, almost I'm increasing pressures without any gain in I'm increasing pressures without any gain in volume. So there is a poor compliant lung. Either this may be a case of RDS. If we give surfactant, then you can see the graph in the green, the compliance starts increasing and the lung starts moving to the left. Now you will see in all the three graphs, that is all the three waves, with the same PIP, the tidal volume keeps on increasing. So with the same PIP, the tidal volume is lowest in the pink, slightly more in the green, and then it has become adequate in the yellow curve. So yellow curve is something which is idle, but green is also acceptable. But the pink one tells me about the poor compliant lung. Usually it happens in RDS, and once we give the surfactant, the curve shifts to the left. That is, with the equal change in the pressures, we get more increase in the tidal volume. So that's what we want. Now, again, there is two important things which we need to learn from this graph is the lower inflection point, so, and the upper inflection point. Usually we want to ventilate between these 2 points. Why? If we ventilate below this point, you will see that we are increasing the pressures but there is no increase in the volume. So that means here we need to increase the PEEP so that the lung is opened up. After that, this point, when we give pressures, we achieve a steep increase in the volume. That is what we want. That with minimal change in pressure, we should achieve a good tidal volume. And if we go beyond this upper point, there will be beaking. That is, there will be again wastage of pressure. That is, will give pressures, but there will again be no increase in volume. So this is unnecessary added pressure which doesn't add to volume but can cause barotrauma, problems like air leak, pneumothorax. So always we'll try to ventilate between this point to this point. So this point is also called as beaking or duck beak sign. And always this can also be measured by something known as C20 by C, where C20 is the compliance of the last 20% of the curve divided by the compliance of the whole curve. Usually it should be 1. If the compliance of the last 20% is less, that is C20 by C is zero point 0.8 or less, that tells me that I'm giving unnecessary excessive pressures to the lung of the baby and I need to come down on the PIP. So you will always see a ventilator giving you that number, that is C20 by C. Or if you look at the PV loop and it shows something like this, a duck beak sign or a beaking, you should decrease your pressures, because as you can see clearly, you are increasing PIP but without gaining any volume. So that means I am giving more pressures than are required for the lung to open. Again, PV loop is also important to tell me about the adequacy of the flow. If the flow is less, then the inspiratory curve will be like it will be giving a flea bitten appearance. That is, something has bitten the curve and there will be a scalloping appearance. So this tells me that the we need to increase on the flow. Majority of the ventilators these days, they automatically regulate the flow, but in some ventilators where we have to set flows, sometimes because of the inadequate flow we'll get a graph like this. Sometimes also there may be a figure of 8 that is again tells me that the flow is inadequate. Now also this loop or the PV loop is also important to know about whether my lungs are opened up or not. As you can see to the left, that is, I am giving a pressure of 6 without opening the lung or without gaining any volume. That tells me that there is atelectasis, lungs are not opened up. As I increase the PEEP to 5, that is, I open the lung and then I give the pressures, you can see a smooth, steep rise in the pressures with the rise in pressures. So the graph on the left was atelectasis because of the inadequate PEEP. As we increase the PEEP to 5 or 6, the lung opens up and then we give PIP and we can see an equal rise in the volume and lung opening up and giving this PV loop. Also, the PV loop, if we are giving assisted breath, that is if the patient, it's a patient triggered ventilation or a patient triggered breath, initially we will have a negative because the natural breath is a negative one. So initially we will have a negative deflection and then we'll have a positive one. This tells me that this is a assisted breath. This is how a spontaneous breath will look like, and this is how a controlled breath will look like. Again, this is again of one of the graphics which will tell me about the leaks. If the inspiration starts from here, if it doesn't come back to this point, this tells me that there is air leak, again because of this small ET or a leak in the circuit. So PV loop tells me whether my PEEP is adequate or not, or in other words, whether I have opened the lung enough or not. It also tells me about the compliance, especially in a patient of RDS, where the PV loop will almost be like a sleeping curve. As I give the surfactant, the curve will shift to the left. That is, with the equal increase in the pressure, I will get more gain in the volume. It also tells me about the adequacy of the flow. That is, will be a scalping or a flea bitten appearance. And it also will give a beaking appearance if I'm giving more pressures. So that is C20 by C will be 0.8 or less, where I should come down on the pressures so that there is an equal change in volume per unit change in pressure. Coming to the second graphics, where we plot flow versus volume. It's also called as flow volume loop. It is important to know about tube leakage, air trapping, increased resistance, and secretions. Again, in this graph, we have a flow on y-axis, volume on x-axis. So there is a positive inspiration curve. The peak is peak inspiratory flow rate. This gives me the tidal volume, and then we have the peak expiratory flow rate coming back to the baseline. So this is flow volume loop, where flow is on the y-axis and volume is on the x-axis. So whenever there is air leak, the expiration will come and touch the baseline. Here, it will not come back to the initial point. So again, this amount of air is leaking. That's why I will get this appearance. Normally, it should start from here, go to this as inspiration, and then come back to the initial point as expiration. But because of the air leak, it ceases prematurely. And this again tells me that there is leak in the circuit. Similarly, if there is air trapping, it will come to the baseline, but it will never come to the zero. Again, this tells me that there is air trapping and I need to give adequate TE or there is auto PEEP. So whenever, as we discussed in the flow time scalar, that whenever there is increased resistance, it usually happens during the expiration. So what will happen is my peak expiratory flow rate, just like in the flow time graph, it will come down. So initially this was the normal curve. So the peak expiratory flow has come down and there is a scooped out pattern because of the increased resistance. And usually once we give the bronchodilators to such patients, they again come back to normal. Other important thing is whenever we are putting a ET tube, we always need a good nursing care. So almost whenever a baby is ventilated, it is ideal to have 1:1 nurse-sister ratio because ventilation can lead to various complications, even sepsis or VAP, that is ventilation associated pneumonia. So whenever you see a seesaw pattern or serrations like this on the flow volume loop, especially in the expiratory limb, that means there are secretions present and patient needs a suction. So as soon as you do the suction, clear the secretions, again you will get a good expiratory curve like this. So whenever there are serrations, you should know that there are secretions pent up there. Similarly, if there are obstructions, if there is a extrathoracic obstruction, that is obstruction during both inspiration and expiration, that is like a small endotracheal tube or a subglottic stenosis, you will get a square flow volume graph like this. Whereas if there is an obstruction, intrathoracic obstruction, like obstruction the cornea, you will have inspiratory obstruction like this, serrations on the inspiratory flow valve. So again, sometimes patient, especially the term babies, may inadvertently do self extubation. In those cases also, graphics are important, although we don't want such situation to happen in with anybody or with any baby. So usually whenever the flow volume graph looks this, where flow starts but it never comes to the back to the baseline, this can be a sign of self extubation. So you need to be careful. Again, graphics are important to tell me about the mode of ventilation. We talked about the cycling. Usually majority of the modes are time cycled. That is, we set a particular ti, till that ti, unless and until that is finished, the inspiration continues, and after that the cycling happens, that is the expiration starts. But as we discussed in the PSV, that there is something called as termination sensitivity, where there is flow cycling. Flow cycling is important because it also helps us to gain some synchrony in expression also. Our basic aim of being gentle or getting all these things in modern ventilators is to achieve synchrony between the machine and the baby. Because if machine and baby are comfortable with each other, then the clinician, that is neonatologist or the pediatrician, will also be comfortable. If they are not comfortable, they are fighting against each other, then our life will be in misery. So this is a beautiful concept of termination sensitivity, which is used in PSV mode. So usually the termination sensitivity is set at 5 to 25%. So this again can be seen in the flow time graphics. That is the scalar which we discussed earlier. So suppose my peak inspiratory flow rate is 10 and I have set a termination sensitivity of 15%. So as soon as the flow comes to 15% of 10 liters, that is 1.5 liters. So as soon as it comes to 1.5 liters, the cycling will start. That is, the expiration will start. It will not wait for the flow to become zero. So there will be no inspiratory hold. So there will be better synchrony, especially in the expiration, and the cycling will start. So there will not be that unnecessary inspiratory hold where the lungs were exposed to higher pressures without any need for that. So that is called as termination sensitivity. Again, this can be seen with the help of graphics. So as you can see in this, as you can see here, that is, initially it was assist control mode in the first two breaths, and then we changed to PSV. So you can see the narrow peaks in the pressure time graphs and the volume also. Whereas in the initial assist control, you can see that there is an inspiratory hold. That is, the inspiration is complete, but there is a period of zero flow and then the expiration start. As soon as we change it to PSV, because it's the flow cycle, you will see as soon as the inspiration ends, the expiration starts. So there is no inspiratory hold here. So remember that pulmonary graphics is a just like ECG and ABG printout. It gives you the real time assessment of the settings, baby's condition, lung conditions. It also helps us to identify the misadventures before it becomes a catastrophe. So always see the graphics. I hope after this lecture, you will go back to your patient and start looking at the graphics